Good afternoon, everyone, and thank you for joining to this first spotlight in science of the European Society of Endocrinology in this 2024. It is for me a pleasure to be here chairing this session with my co-chair Lina, that will be speaking to you later on. In this session, we continue with a series of seminars that we started last year, and they were dedicated to each of the different focus areas of the European Society of Endocrinology. And in this case, the session is dedicated to adrenal and cardiovascular endocrinology. To do that, we have today two excellent speakers that will be illustrating us about different aspects of hypercortisolism. As always, we will have the two presentations in a row. We will have later time for discussing with the speakers the aspect that you consider more interesting about the topic. You will have the opportunity to send questions through the Q&A button just at the bottom of the screen, or just you can ask them directly opening the camera or the microphone and doing directly the question. So I think we can start with the session. We have as first speaker, Dr. Elena Balassi. She is Associate Professor of Endocrinology at the International University of Catalonia in Spain. She is a Principal Investigator of Competitive Grants focused on pituitary diseases and coordinator of the Pituitary and Adrenal Clinic at the German Trials and Pujol Hospital and Research Institute of Badalona in Spain. She is also responsible for data quality of the European Registry of Cushing Syndrome that is hosted by the European Society of Endocrinology. After obtaining her medical degree at the University of Pavia in Italy and her specialization at the University of Modena, also in Italy, she obtained her PhD in endocrinology from the University of Milan and completed her formation at the Reproductive Endocrinology and Neuroendocrine Unit in Boston, US. After that, she joined the Research Center for Pituitary Diseases at the Hospital Sant Pau in Barcelona. She has been interesting from the research point of view in long-term physical and psychological consequences of pituitary hormone excess in patient-reported outcomes and in medical therapy in Cushing syndrome. She has published more than 80 articles and received national and international awards, including the Spanish Society of Endocrinology Adrenal Disease Award or the European Journal of Endocrinology Rising Star Award. She is obviously an international expert, a member of the Medical Advisory Board of National and International Association of Patients with Pituitary Diseases, and she will be talking today about long-term consequences of endogenous Cushing syndrome. So if you are ready, Elena, it's a pleasure for us to have you here. So the floor is yours.
Thank you. Thank you, Manuel, for the invitation, and thank you, the European Society of Endocrinology. It's a big honor to participate in this very nice initiative. Okay, so we know very well that hypercortisolism in Cushing syndrome is associated with a plethora of complications, including cardiometabolic alterations, such as left ventricle hypertrophy, fibrosis, but also increased visceral fat, and with a negative adipokine patterns, secretory patterns. And then we have musculoskeletal dysfunctions, such as myopathy, osteoporosis, vertebral fractures. We have neuropsychiatric disorders, and increased atherosclerotic risk, and increased thromboembolic risk, and an elevated risk of infections. So all these complications do not completely revert after correction of hypercortisolism. After successful treatment, the recovery for patients is slow and incomplete, probably due to the fact that there is still working the effect, the deleterious effect of previous exposure to glucocorticoids on several glucocorticoid sensitive tissues. So the effects probably are partially reversible or irreversible. And this, of course, as you can imagine, strongly affect quality of life of patients and also survival. This has been clearly demonstrated in these two interesting studies, showing that there is excessive cardiovascular morbidity in patients, even long-term, even decades after remission is achieved. In particular, as we can see here, the hazard ratio for myocardial infarction and stroke is more elevated than the general population, and is still more elevated if only initially cured patients are considered, 186, and the hazard ratio for myocardial infarction is still very elevated, it's 4.3. And in this Swedish population study, including 296 patients, again, we can see that the occurrence of stroke calculated using the standardized incident ratio is 4.9, so it's elevated, it's more elevated than the general population from diagnosis to 1 year after remission, and remain elevated even 7 years after remission with a standardized incident ratio of 3.1. And interestingly, there is no difference between pituitary dependent and adrenal dependent Cushing. So the etiology does not interfere, we could say. And in terms of mortality, the same. So of course, mortality in patients in active or persistent Cushing syndrome is more elevated than the general population, but even after 30 years after remission, the standardized mortality ratio is 1.9 overall, and in particular, due to circulatory heart disease, the standardized mortality ratio is 2.5, and for ischemic heart disease is 2.7. And this concept, the concept related to the increased mortality, especially cardiovascular mortality in patients with Cushing, is further emphasizing this very interesting and important study involving 6 tertiary referral centers in UK. And again, we can see the overall mortality is increased in patients who have been in remission for more than 10 years, and especially again due to circulatory disease, 2.72. And here it's important because the predictive factor for mortality is are especially related to the presence of treated diabetes. So those patients who had diabetes, even treated diabetes, had a higher mortality. The hazard ratio was 2.82. And in a previous study by the same first author of the multicentric study, also concomitant hypertension was another important predictive factor for mortality. So the concomitance, the coexistence of diabetes is important also in terms of increased prevalence of infection as a cause of death. In the European Registry of Cushing syndrome, we have demonstrated that when we excluded patients with ectopic Cushing, that of course had a particularly elevated mortality rate due to the progression of the underlying disease, infection is the main cause of death, 31% in pituitary dependent and adrenal dependent Cushing. And this is especially true for patients with diabetes. So patients who died more frequently had diabetes and or muscle weakness, not only at last follow-up after 38 months, but also in terms of perioperative mortality, so within 90 days from surgery. So, of course, the big question is what happens to hypertension and diabetes after remission? What is the prevalence of these important comorbidities of hypercortisolism? So here there are 3 studies, including a good number of subjects, a good number of patients. And as far as hypertension, we can see here, for example, the article by Hassan Smith, again, is a study from UK. We can see that at diagnosis, the prevalence of hypertension was 78%, and after remission, The prevalence of hypertension was still high because 1/3 of the patient experienced resolution, a full resolution, but 30% only a slight partial improvement. And in terms of diabetes, we can see that the percentage is pretty much the same, so does not change significantly as compared with baseline in any of the studies analyzed. So definitely there is a persistence of a negative cardiometabolic pattern in patients in remission, especially even in long-term remission. And it's quite evident in these two cross-sectional studies, we can see that the diastolic blood pressure is still higher 5 years after remission, after biochemical remission is achieved, and there is a negative lipidic profile. But it's particularly important also that the body composition remain altered even more than 10 years after remission, with an increased percentage of trunk fat mass, which of course is associated with a negative adipokine secretory pattern. In particular, adiponectin levels are lower in patients with Cushing syndrome in remission as compared with the BMI matched controls, but the levels of TNF-F1 are increased, so indicating that despite remission, there is a persistent status subclinical of inflammatory, pro-inflammatory status, which is probably associated with the persistence of the cardiovascular risk we have mentioned before. And indeed, this pro-inflammatory status is probably the leading factor to develop or to maintain an increased intima media thickness in patients in remission. In this study using the Doppler, we can see that the diastolic peak velocity was increased and the distensibility coefficient was decreased in patients in remission. And overall, almost 1/3 of the patients had well-defined plaques. So this, of course, is related to what? So there are many factors, of course, which can condition and influence the persistence of an increased atherosclerotic risk in patients with Cushing syndrome in remission. But among them, probably these are the most important. Of course, the comorbidities, we have seen that before, the persistence of trunk fat, the central adiposity, the coexistence, again, of type 2 diabetes, of course. Also, shorter time to remission seems to be associated with a higher risk, of course, because it means that patient probably had a more severe hypercortisolism and only a partial or apparent remission early after surgery, or they have a higher risk of relapse. But also, of course, there is a direct effect probably of cortisol, so not only mediated by the comorbidities. And this is probably due to the fact that high cortisol levels inhibit the synthesis and the release of nitric oxide, and also prepare a microenvironment of oxidative stress and pro-inflammation. And interestingly, it has been suggested that ACTH may have a direct effect detrimental to the vessels. In particular, in animal models, it has been shown that ACTH is able to promote the transformation to the linear osteochondrogenic lineage of the mesenchymal stem cells. So inducing this, of course, the risk of calcified plaques is higher. And actually, if we take a look at this attack based on this study based on multi-detector CT, we can see that the alteration of the coronary alterations are more frequent in patients with Cushing syndrome in remission as compared with controls. Unfortunately, controls were not matched in terms of smoking habits and hypertension. But if we analyze, when the authors analyze only women younger than 45, it's quite evident that the prevalence of non-calcified plaque was higher in them as compared with control that actually did not have any plaques. So definitely there is an important impact of previous hypercortisolism. And how about the cardiac structure and functional alterations? So of course, during the active phase of Cushing, there is the hypertrophy of left ventricle, and there is systolic dysfunction, especially on the left atrium. And progressively, this alteration change and improve early after remission. After 6 months in this study, it has been shown that, in particular, the left ventricle mass index decrease in patients in remission, in parallel with a decrease in fasting glucose and BMI. So again, the importance of the comorbidity. Again, we cannot exclude a direct effect of cortisol, probably via glucocorticoid and mineralocorticoid receptor, but also a possible activation of the adrenergic receptors. But another very important aspect is related to the accumulation of fat in the heart. So the authors demonstrated that there is not myosteatosis in the myocardium and myocardium of patients with active Cushing, but there is an increase in both epicardial fat and pericardial fat. We know very well that Cushing is a fat partitioning condition. So in the condition where ectopic fat deposits generate. And this is, of course, deleterious for many aspects. So here the authors demonstrated that after 9 months of remission, there is a progressive decrease in ectopic fat. And this is very positive, of course, because the ectopic fat is a kind of fat which share the same blood supply than myocytes, and is strictly, there is a contiguity with the myocytes because there isn't any fascia separating the myocytes and the epicardial fat. So of course there is a continuous flux of adipokines and mesenchymal cells from the epicardial fat to the myocytes, and this is detrimental to the contractile properties in particular. So very important the epicardial fat reduce, because probably this is also linked to a reduction of fibrosis, and we'll see that in a minute. Pericardial fat, which is a more classical, we could say, visceral fat, does not change, but probably is also due to the short follow-up period. So hopefully with a longer follow-up, probably pericardial fat will ameliorate again as well. And exactly in terms of fibrosis, we can see that after remission, there is a significant improvement, a significant reduction of fibrosis in the myocardium, which is not associated with hypertension or left ventricle hypertrophy. So it's totally independent from that. So again, probably there is a direct effect of cortisol here, but also, as I said before, probably the epicardial fat and the decrease in epicardial fat plays an important role. And we cannot forget the thromboembolic risk. We know that there is a high risk of thromboembolism after surgery. And in the European Registry of Cushing syndrome, we have just demonstrated that this risk may remain, we could say, until 17 months after surgery, at least in the patients we are including that are more than 2,000. And but most of the events occur within 6 months. Probably due to the drop. There are many theories. Of course, we don't know very well what are the mechanisms. Probably is linked to the rapid drop of cortisol in these patients, and so the paradoxical increase of a prothrombotic state. But it's not only the case, because of course patients with persistent Cushing, of course, with unsuccessful surgery, have a even higher risk of thromboembolic events. And in terms of the cardiometabolic risk, I think that we should not forget a potential effect of gut microbial dysbiosis. We have recently demonstrated that there is dysbiosis in patients with Cushing syndrome in remission. In particular, there is less richness, as demonstrated here by the Chow-1 index, and less diversity, and also some peculiar characteristics. For example, the Collinsella, which is a genus from the Actinobacteria phylum, is more represented in Cushing, as practically absent in controls. And this is a pattern which has been observed also in obese patients and in patients with type 2 diabetes and atherosclerosis. So probably there is an interesting link that should be further studied. And then Sutterella, which is a genus from Proteobacteria phylum, is the opposite, so it's not represented in Cushing. And this also observed in patients, again, with type 2 diabetes and depression. So the link, the gut-brain link, of course, is a very interesting aspect. And interesting, the Chow-1 index, so the low richness of microbiome, was negatively associated with glycemia, OMA, insulin resistance, and triglycerides. So in terms of the body composition in patients in remission, we have seen before that there is a persistently increased trunk fat percentage. So in this study, this prospective study using MRI, it's been shown that the patient progressively decrease their visceral fat and subcutaneous fat. So we can see that the main fat depots reduce after remission, 20 months after remission. But this is not true for the intermuscular fat, which is the fat included between the muscle groups and beneath the fascia. So somehow the fat into the muscle does not change. So we extend this finding, demonstrated that two important things. The first one is that there is the persistence of muscle dysfunction long-term after remission, more than 13 years after remission, and this was assessed using very easy muscle functionality test that can be used in daily practice. And this was also demonstrated by the German registry of Cushing. So there is a persistent muscle dysfunction in the long term. And we also demonstrated using the Dixon software applied to MRI that there is a persistent fatty infiltration in the muscle of thigh. And this fatty infiltration is associated with muscle dysfunction. So it's an important contributor to contractile dysfunction in patients with Cushing. And we know that muscle weakness is one of the most important complaints in the patient even after biochemical remission. So what are the potential mechanisms linking fatty infiltration, so myosteatosis, and impaired muscle contraction? So certainly there are mechanical effects because the presence of adipose tissue in muscle can block muscle activation, changing muscle fiber orientation and the fiber penetration angle. So this, of course, impair contractility because there is an obstacle somehow, a mechanical obstacle. But also there is an important metabolic causes, of course. On the one hand, we know very well that muscle control insulin sensitivity. So the presence of adipose tissue there induce insulin resistance, reducing the glucose uptake, and so reducing the pool of ATP. And on the other end, of course, as I said before, the presence of fat produce a lot of adipokines. So these adipokines, again, alter contractility, and this has been seen in many animal models. Another important contributor to maintain muscle dysfunction in the long term is certainly the IGF-1 status, because we know very well that IGF-1 is anabolic, and in muscle tissues, an important factor that support and enhance myoblast differentiation. So the group of Martin Reinke demonstrated that there is a direct relationship between IGF-1 levels and the hand grip strength. So the higher is IGF-1, the better and the more rapid will be the recovery of muscle strength after surgery. So the importance of checking IGF-1 and, of course, substitute and replace if it's necessary. And in terms of bone, what happens? Well, we can see here that, again, from the German group, the Munich group, we can see here that in the first 2 years after surgical remission, there is a progressive increase in the normalization of bone remodeling. In particular, bone formation markers progressively increase, bone resorption markers increase more slower, but within 2 years they can normalize. And this is paralleled by an improvement in bone mineral density as demonstrated using densitometry, using DEXA. And this actually confirmed previous studies where it was shown that after long-term remission, the bone mineral density as assessed using DEXA, the aerial bone mineral density, normalized. except in some population, or in some cases, for example, glucocorticoid replacement can be a predictor of incomplete recovery of bone, and the same as for some polymorphism, especially those involving the glucocorticoid receptor gene. But apart from this, in general, aerial bone mineral density recovers. But what happened to bone quality? So we have very recently demonstrated using a quantitative computed tomography-based finite element analysis that all strain and stress markers at femoral neck are still increased in patients in long-term remission. As we can see here, this means that under a given loading condition, pushing patient exhibit more elevated strain and stress, so they may reach the threshold of mechanical failure earlier than controls when exposed to comparable loads. So this means that there is more fragility and more tendency to fractures, but of course these results should be confirmed in further study, larger studies, but we have to say that the older age was a special predictor of this. So the impact of previous hypercortisolism in aging, I think, is an aspect that we should study more in depth. And also we showed that the trabecular bone mineral density, volumetric bone mineral density is reduced in these patients. And also the buckling ratio, which is an index of instability, is higher, so more instability and risk of fracture. And cortical thickness is lower in Cushing syndrome as compared with controls. And this has been found again in elderly people, especially in the subtrochanteric region. So this may indicate a particular fragile area in the proximal femur. And then let's talk a little bit about the neuropsychiatric dysfunctions. So we know that there are many areas in the brain which are glucocorticoid.
Oh, warm is it in Florida?
Which are glucocorticoid sensitive, in particular the so-called neurocircuitry of stress, which is represented by amygdala, hippocampus, and the anterior cingulate cortex. So this area, the limbic area, this area experience a progressive reduction of their volume during the active phase, which does not completely restore after remission. There is brain atrophy in this area, decreased cortical thickness, decreased gray matter, and white matter. And of course, there are also deficits in both cognitive function and psychopathology, because these are areas involved in the emotional processing and in the memory, for example, in stress responsivity. So of course, there is a significant psychopathology in these patients. And also there are functionality alterations that have been recently discovered and described using functional MRI, and we will see them in details. So the first concept, which is very important to remember, is that it's very difficult to find a correlation between the structural alteration and functional alteration. We don't know why, probably because we don't have tools which are sensitive enough to that, or maybe it's the connection, this kind of association is more evident using functional MRI. Anyway, this has been the first description of a connection between structural alteration and functional alteration, because here the authors demonstrated a widespread reduction in white matter integrity. So we can see that the fractional anisotropy, which is the marker reflecting this reduction, was also associated with depressive symptoms. So this is very interesting. And using functional MRI, as I said before, the results are extremely interesting, even more interesting, because we can see that at rest, there is an increased resting state connectivity between the limbic network and the anterior cingulate cortex. And then when we apply a task, a memory task, for example, or recognition of emotional phases, there is a reduced functional brain response. So this means that patient experience a status of subtle hyperactivation, which may impair the stress responsivity in basal situation. But when there is a stimulus, they are not able to generate an adequate response. So this means, of course, having said all this, that there is a significant persistence of both physical and psychosocial stressors in patients despite remission. Here there is a summary of the main residual morbidity we have just talked about. And of course, these persistent stressors, this persistent condition of stress negatively influence many aspects of patient life, work life, social life, sexual life, relationship, and of course also the work status, the economic situation is an important socioeconomical burden indeed. So if we compare the quality of life in patients in remission, which is indicated here by this orange line, the red line is during the active phase, we can see that there is a significant deterioration, much more than that observed in other models of pituitary adenomas, not only non-functioning pituitary adenomas, but also in acromegaly patients. We can see here that pain, for example, or vitality or general health practically do not change after remission, and there is a very subtle modification as compared with baseline. So this poor quality of life is, of course, related to factors which are linked to all kinds of pituitary adenomas, for example, hyperpituitarism. But there are some factors, as we have said before, that are specific for Cushing, being the most important being delay to diagnosis, depression, and muscle dysfunction. So in the European Registry on Cushing syndrome, we had shown that after 38 months after the treatment, the total Cushing-Qual score, the Cushing-Qual is disease-generated questionnaire, one of the disease-generated questionnaires, so is still lower, the Cushing-Qual, in Cushing patients, in particular in pituitary-dependent Cushing as compared with adrenal-dependent Cushing, and is still is higher than baseline, but still lower. And if we look at each item, for example, leisure time, memory, and worries on future health, again, are more deteriorated in pituitary-dependent Cushing as compared with adrenal Cushing. But when only patients in remission were considered, this difference was no longer significant. So we can say that quality of life is still deteriorated in the long term, although a minimal certain improvement is certainly observed. And it's very important to underline that older age again and depression at baseline were significant predictor of worse quality of life in the long term. So are we as a physician aware of this or not? So we conducted a parallel survey between physicians and patients and asked them to indicate what are the most bothersome symptoms in the post-treatment phase. So patients answered that for them, the most bothersome symptoms are cognitive impairment, muscle weakness, depression, and also weight gain. So we asked the same question to the physician, to endocrinologist, and they answered, as we can see here, most of them considered that less than 1/3 of their patients suffer from cognitive impairment, muscle weakness, depression, and weight gain, which means that there is an important dissociation and discrepancy between the perspective of the patient and the perspective of the physician. We, as a physician, are not completely aware of the burden of this residual morbidity, muscle in particular, and cognitive and mood on our patients. And of course, if a symptom is under-recognized, of course, it means that is not addressed properly. And actually, the patients said that they did not see the specific specialist that could help them overcome and treat this residual morbidity in most of the cases, because a dietitian was only seen by 10% of the patients, for example, and a physiotherapist by 14%, and a psychologist or psychiatrist only was consulted in 23% of cases. So, and this is reflected, as I said before, there is not only a personal burden, but also a socioeconomical burden. So this is reflected by this study, interesting study, where it has been shown that use of psychotropic agents continue long-term and does not change in patients in remission. We can see here that antidepressants at 5 years after remission at 10 is exactly the same as in baseline, and the use of anxiolytic reduce, but only after 10 years. And in general, use of antidepressants, sleep pills, and antihypertensive, antidiabetics remain higher in Cushing patients in remission as compared with the general population at 5 years. And there is no difference as compared with patients with persistent Cushing before than 10 years. After remission. So it's a very, very, very important, and we should think about how to improve our patient health. So in conclusion, cardiometabolic, musculoskeletal, and neuropsychiatric dysfunction are partially reversible in patients with Cushing syndrome after correction of cortisol excess, which contribute to maintain poor quality of life and high mortality. Periodic laboratory and clinical assessment and proper management of comorbidities such as hypertension, diabetes, and dyslipidemia should be carried out to normalize life expectancy. And lifelong monitoring within a multidisciplinary team is highly recommended to treat physical and psychological stressors that affect patient well-being and raise health costs. So thank you very much for your attention.
Thank you very much, Elena, for this great presentation. So now it's time to move to the second speaker. So Lina, if you want.
Elena, thank you. This was fantastic. Great overview of the clinical implications of hypercortisolism. And now it's my great honor to introduce Professor Ruth Andrew. It's a great honor to have you with us, Professor. A few words about her. Ruth Andrew holds a chair in pharmaceutical endocrinology at the University of Edinburgh and directs the clinical research facility mass spectrometry core. Ruth developed her career in steroid profiling in cardiometabolic disease, investigating regulation of glucocorticoid metabolism. Her group has focused on the role of hepatic reductase in diabetes and in dynamic methods to quantify steroid metabolic pathways in vivo using stable isotope tracers and imaging. She leads a team specializing in small molecule quantitative analysis in support of translational medicine, most recently visualizing steroid hormone networks using mass spectrometry imaging. Ruth Andrew is currently the General Secretary of the Society of Endocrinology and co-editor-in-chief for the Journals of Endocrinology and Molecular Endocrinology. Dr. Ruth, is again our great honor to have you with us. Just to mention that we have incredible numbers of participants today, more than 100. So the floor is yours and we are ready to enjoy your talk.
Thank you very much. Can you hear me okay?
Yep.
Yeah, great. Thank you. And thank you very much for the invitation. It really is an honor to speak for the ESE and also in conjunction with Elena. So I'm going to try and give you a basic science perspective on, I guess, glucocorticoids, what's next, because what we've heard from the previous talk is, while we understand a lot of endocrinology, there's still a lot of challenges in treating it. So I thought I would try to focus in on maybe areas that are up and coming that perhaps haven't reached therapeutic potentials yet, but that I think there are opportunities there for us to develop. So I'll take you through my view of what's new, really. So just as a background to start off with, of course, we're talking about glucocorticoid hormone, cortisol, and my background's a chemist, so I like to draw the structures. So here we have the glucocorticoid hormone with its 4 rings and its various hydroxyls and ketone groups that give it its specific functionality. It's produced from the adrenal glands, that's the topic of today, and drives a very large number of biological processes that are absolutely critical for physiology. And again, we've heard from Elena what happens when those go wrong. I've highlighted stress responses and metabolism because that's what I'm going to talk about, not that the others aren't any less important. So this can go wrong, and when, for example, when the regulation of metabolism goes wrong, we end up with problems with cardiovascular disease, if we've heard, diabetes. We can end up with cognitive disease and a number of other issues. And that's absolutely characteristic of Cushing's syndrome and Cushing's disease, shown here. But there's been a suggestion that perhaps those people, individuals in the population that show these features of the cardiometabolic syndrome might in some way be exhibiting some form of cortisol excess in natural life without a tumour. What's great about, I guess, knowing that Cushing's syndrome is reversible means that you might think there's a way of intervening there for these people if they have a natural sort of cortisol excess that we're perhaps not picking up. We also know this from people receiving glucocorticoids as anti-inflammatory agents, from treating asthma and various other immune disorders. When you take away the glucocorticoids, you can improve things. So how can we intervene without really being a very blunt, it's very dangerous to just remove glucocorticoids and leave people exposed, but are there other more subtle ways of manipulating the glucocorticoid syndrome? So here's our sort of textbook hypothalamic pituitary adrenal axis, where the cortisol is produced, goes into the blood, hits the tissue, and we're taught that it takes there for several hours or so for the effects to arise because of the gene transcription effects. And what I'm going to do is just sort of show you what's new in this field, where maybe that's not as, it's more complicated than that, I guess, is what we want to say. So first of all, just focusing in the adrenal gland, we have the adrenal sitting on top of the kidney with its various functional zones, and each functional zone producing its own diverse group of steroids. So the glomerulosa driving mineralocorticoid synthesis, fasciculata for glucocorticoids, and reticularis for androgens mainly. Now, there's an exception for that when we've got the fetal zone present, but that's largely what we see in the adult human. And that actually is the home of the steroid metabolic and synthesis pathways. So glucocorticoids start with cholesterol, and we have to come all the way over to this side here to get to our glucocorticoids here, which is cortisol being the main one in humans. But we mustn't forget there's also another glucocorticoid formed, corticosterone, which can act as a backup under certain circumstances. But maybe it's got another role, and I'll come to that in a bit. There are a lot of enzymatic steps. Each of these arrows has got an enzyme involved with it. So what we can see is to get through to cortisol is actually there are a lot of biochemically regulated steps that all have their own velocities and kms, etc. So perhaps just measuring cortisol on its own is not as informative as measuring the whole pathway and the flux through the pathway. So that then brings about challenges in accurate measurement, which is one of my interests, where I use mass spectrometry to help us accurately and precisely measure flux rather than just the individual steroids. I also wanted to highlight there are another set of enzymes that remove the glucocorticoids. These are the ones that I've highlighted in yellow. The SRD5A1 gene drives the 5-alpha reductases, AKR1D1, 5-beta reductase, and there are other enzymes, CBR1, 20-hydroxylase. We've got conjugation that helps make the steroids more water soluble. And of course, the 11-beta hydroxysteroid dehydrogenase is the sort of reversible pair of enzymes that shuttle cortisol between itself and an inert metabolite. So these all have roles to play as well in regulating the amount of active glucocorticoids that there, and they also have to be taken into that overall profile as you look at it. Before I move on, just to say that these enzymes don't just metabolize glucocorticoids, they show up at other parts of the biochemical pathway, and I think most particularly recently we've started to learn about hydroxy and ketoandrogens, hydroxy and ketoestrogens. These involve some of the same enzymes. And I think if you look at the literature, people tend to be a bit siloed in saying, I'm studying these enzymes, therefore the outcome must be glucocorticoids. I think we need to take a little bit more of a broader view. There's an interplay between all the sets of steroids once something goes wrong in this pathway. But if we're to measure this flux, then I think that's why we need very good ways of doing that. And as my introduction said, I run the mass spectrometry core facility in Edinburgh, and that is an area where we try to develop these steroid profiles. And it's very challenging because if you look at this is plasma levels, if you look at the y-axis, there's like a 5-fold order of magnitude difference in the levels of steroids. And this brings about quite a lot of difficulties for analytical chemists. So when we used a lot of immunoassays to measure steroids, if you were perhaps measuring aldosterone here or estrogens here, which were down the low end, you were trying to do it in the context of very high abundance steroids being there as well. And that even slightest cross-reactivity with the antibodies caused problems. And steroids are all very similar in structure, so it's not unreasonable that they interfere. So there was quite a landmark paper in this one here in Journal of Clinical Endocrinology Metabolism back in 2013, which for sex steroids started to insist that mass spectrometry was used as the tool to actually accurately, precisely measure steroids. And this was particularly focused at the low abundance steroids such as testosterone in women and older men, for example. But it's very much got rolled out that mass spectrometry has now become the sort of gold standard for all steroid analysis in research as well as in the clinic. We often use this Mayo Clinic's lab website, which is quite handy for human reference values. And it's noticeable now, you see we've got a reference range that's by mass spectrometry. So it is very important that we pay attention to that when we're quoting these reference ranges. But I think mass spectrometry has moved on, and fortunately now we can start to apply these standards of good analysis in the preclinical environment too, because we can measure at lower levels and in smaller volumes, opening up like rodent research. So I'd encourage people to think about doing that, moving away from immunoassays where they can. That profiling offers a lot more insight than just measuring the single hormones. This is an example of a gas chromatogram, one of my very early ones. And what we can do here is measure all the profile of the steroids that come out, usually measured in urine. And now the work of Nils Krohn started this field to move forward into what now has become machine learning and omics. But here, this set of steroids that are formed from the adrenal gland were divided up into their groups and measured with their normal ranges, and then used in various settings in order to distinguish disease. So this is one particular patient set, I think, with an enzyme deficiency, where you can see that there's differences in these black dots. These are the diseased patients. And you get much more power for measuring identifying the disease by using the profile, using more than one steroid in the diagnostic. So this was done by Nils back in 2010, but along with Wiebke Arlt, this work has really expanded to look into, for example, trying to differentiate different types of adrenal tumours using these profiles of steroids rather than just measuring one individual metabolite of cortisol, for example. So I think this is maybe my first highlight of this as an area to watch. When you start to work with multiple profiles, you need to start moving into artificial intelligence and machine learning. And that's an area where that group in particular has pushed forward. So I think that's a very valuable area to keep an eye on. And it lends itself to clinical diagnostics because these types of technologies are already in the hospital. So back to my simplified model here. The next thing I'd just like to look at is what about in the blood? What about if we do measure cortisol in blood? Is this one blue dot really what we're measuring, which is my representative cortisol? Oops, sorry. Well, first, actually, what we would ask is, does it state, what would you say if I said, what does cortisol do during the day? Well, what most people would tell you is you've a circadian rhythm where you've got higher in the morning and lower in the evening, and that's certainly right on an average basis. But actually what we see are pulses during the day. And this is a figure from Mike Shipston's review here, where he has tried to use mathematical fluxes to try and understand these ultradian pulses. They pulse roughly about once an hour. So what this is telling you is that there's a more dynamic control of cortisol than we currently think about. And certainly if we were to use glucocorticoid replacement, we do not remotely start to replace in a pulsing manner. But does this matter? And I don't think we understand that yet, but for sure these pulses have different patterns, whether they're peaks or frequency in diseases such as depression. And if you sort of draw the analogy with the LH pulse generator, peaks frequencies actually make a big difference there on sort of reproduction. So I think this again is an area to watch. I mean, we're not got any reason yet to say that we should replace in pulses, but actually that might be something that comes, and it would require almost like your insulin pump technology. We've started to learn about this because, again, of advances in technology, and Stafford Lightman and Thomas Upman have led the field here, I think, in allowing us to be able to measure these 24-hour patterns. And you do this using a microdialysis device here just under the skin. You can also place this in tissue, which allows you to get very, very rapid and frequent measures of what's happening with the cortisol and other steroids in the circulation. So the graph here shows a number of people with their traces in blue, all pulsing up and down with these frequent pulses and rhythms, which do average out in red to our, our average daily rhythm, but you can see the variation between people. So this is technology that again has led to greater insights, and I'm sure that the team are certainly trying to look in more stressed situations and seeing how we can try to understand better how to conduct glucocorticoid replacement. So again, that's another area I think it's worth watching. Okay, back to my blue dot. So this is the cortisol in the blood. Is that all we're measuring? Well, in blood, there's also another depot of cortisol, and that's cortisol that's bound to globulins. And the main one for glucocorticoids being corticosteroid binding globulin, but also albumin. And when we make a measurement, usually with a mass spectrometer, actually the processing displaces the glucocorticoid from the binding globulin. So you measure the total. Actually, in the blood, it's only the free that's got the potential to enter the cells, as far as we know at the moment. So therefore, what you're measuring is not necessarily the true representation of the cortisol that's available for its biological function. Now, the equilibrium might be similar all the time, but again, these are equilibria, so they could get disturbed in disease states, such as if there's a situation where something alters the displacement of cortisol from its binding globulin. And we know, for example, inflammation is one of those features because of it's a neutrophil-driven enzyme that helps with this displacement. So perhaps, again, it's something to think about, particularly if you're in wanting to understand the amount of bioavailable steroid, that you maybe should be thinking in your studies to measure the free steroid. And again, that has become available with advances in analytical technology, because we can now measure 10-fold lower levels of cortisol, so it's possible to measure the free. You can do it by surrogate. Saliva, CSF tend to only represent the free levels because they naturally sort of filter in. But there are techniques, again, equilibrium dialysis, ultrafiltration, where you can put your blood sample on one side of some form of filter and only the free can pass through. So you can then measure the free and work out what's going there. So that again is an important thing to think about. Some of my colleagues have looked at the gene that regulates CBG, and indeed there are a lot of people in the population with modifications to that gene, common polymorphisms, and that does actually influence the prevailing level of morning cortisol. So alongside very many other features, differences in your encoding of the CBG gene might affect overall exposure to cortisol throughout life. So I think CBG shouldn't be ignored, and I think that's again an area to watch. So I've moved my cortisol over to its cell. This is a very simplified cell where sort of steroid comes in, gets onto its receptor and goes to the nucleus, where it drives gene transcription or modifies gene transcription. So it's much more complicated than that. I've already introduced you to CBG, which can't we believe the CBG bound to cortisol doesn't pass across the membrane. Now, that's certainly what we think, but what possibly is the case that it could bind at the membrane and still have an effect. Now, that's not been shown for CBG, but in the field of SHBG, which is the sex hormone binding globulin, there's a receptor now known to bind SHBG on the surface. And while it's still early days in that research, it's been shown that that bound steroid can actually have a different type of effect, sort of non-genomic style effect. So we certainly don't know that about CBG, but it shouldn't be dismissed as an option. I'm going to going back to the free steroid here, though. The free steroid is lipophilic, passes across the membrane and enters the cell. And this is quite a complex diagram taken from a colleague's review. We'll go back and just mention corticosterone. It's the other active glucocorticoid. It can also enter the cell. So potentially both of these steroids could be acting ultimately downstream on our receptors over here. What has been interesting, evolving idea is the fact that these steroids can actually be pumped back out of cells, and these transporters ABCB1 and C1 have both had some attention here, because interestingly they don't pump the same types of steroids. So ACB1 will pump your cortisol out of the cell, and ABCC1 will pump your corticosterone out of the cell. Now, these were previously known as multi-drug resistant pumps, and they're the same types of things that pump, anti-cancer drugs out of cells. So if these steroids transporters are differently expressed in different tissues, it might well be that different cells in the body are seeing different proportions or different exposures of corticosteroid and cortisol. So that's just shown here again from that same review. Steroids, for example, that are pumped out by ABCB1, that will extrude cortisol. That's what happens at the blood-brain barrier. This also extrudes dexamethasone. We know that from trying to treat brain inflammation, you have to give higher levels of dexamethasone because it gets pumped out. That's this pump. Placenta has both, so it will try to extrude both ABC1 and cortisol and corticosterone, whereas adipose, in contrast, only extrudes corticosterone. And this has led one group, again, of colleagues of mine to propose that perhaps corticosterone might be a more metabolically safer steroid to give. It can still get into the brain, but possibly it doesn't have such an effect in adipose. So those are hypotheses to be proven, but it makes you think that designing the transporter capacity into a new synthetic steroid is something that's worth thinking about, because I've just highlighted a few down here. They are different synthetic steroids are pumped differently by these pumps. So again, it's not reached its area of therapeutic potential, but it's an area to watch. So the area that I think is probably the best understood in the cell is metabolism, and we have a number of different enzymes. We have 11-beta-HSDs, as I mentioned, these 5-alpha reductases, carbonyl reductase. I'll just talk about 11-beta-HSDs first, because they're probably the best well-established enzymes that are known to modulate glucocorticoid exposure in the cell. So if we go back to this same model, once we get the cortisol into the tissue, then it enters the cortisol in its active state. But in some enzymes will turn the cortisol into an inert steroid, and some enzymes will reactivate it. So essentially means we've got two ways of forming active glucocorticoid, either from the adrenal or within certain tissues themselves. I've highlighted 11-beta-HSD1 as the activated one. I've also said 2 because the synthetic steroids actually are activated by 11-beta-HSD2, so it's not something that's always considered. So thinking about these 11-beta-HSDs, then which tissues can make or inactivate glucocorticoids? And very broadly, the brain and the liver and the adipose tissue are known to be sites of expression of 11-beta-HSD1, so they more likely are going to generate active glucocorticoid, whereas the kidney and the placenta act as protection mechanisms where they inactivate glucocorticoids. Our own studies have used to stabilize total flux to try and measure the amounts of steroids produced across these tissues, and the liver by far is the greatest producer of steroids, but the adipose does make a significant contribution, the brain less so, at least not spilling over into the circulation. So this enzyme here has received a lot of attention to see whether by dampening down these local productions of glucocorticoid can have therapeutic benefit. So the concept is that if you stop the inactive glucocorticoid being activated into the active glucocorticoid, you can lower the local glucocorticoid levels and therefore maybe see metabolic or cognitive benefits. They were first studied in sort of metabolic studies in rodents, where we were looking at sort of metabolically challenged animals to see whether or not the drugs could actually improve their phenotype. And they were successful. The drugs attenuated weight gain, they improved glucose tolerance, they lowered fasting insulin, they lowered blood pressure, they've had effects on plaques as well, to link to what Elena was saying. And this was married by the 11-beta-HSD1 knockout, which had the same types of phenotypes. This has prompted a really active drug development program, which has been very successful actually, and our team in Edinburgh, led by Scott Webster and Brian Walker, have actually been involved with this now, and not as have another number of other drug development companies. And I've just shown you a few titles here to show that the drugs were first tested to try to improve the metabolic phenotype in a number of different settings. But for example, in type 2 diabetes, they did reduce the HbA1c. They didn't, however, do it more than drugs that were already on the market, which has stymied to some extent these drugs being developed further by the companies. But they do have beneficial metabolic profiles, which means even if they're getting used for other indications, they will probably improve those comorbidities. So other areas where there's interest in them is, for example, in treating aging skin and diabetic skin with Anna Tignescu in Leeds. Another colleague of mine, Gillian Gray, looking at them in myocardial infarction repair. And I'm just going to show you where they're getting used actually for cognitive dysfunction, where they're actually in phase 2 trials now, where people are using 11-beta-HSD1 inhibitors to lower the glucocorticoid in the brain and hopefully allow less damage to the neurons. And that's being brought forward in terms of Alzheimer's disease. And these are just a couple of the papers that are out there showing that there's less decline in cognition. There's even in normal patients and also in Alzheimer's disease patients. And you're able to see that the drug actually binds by PET scans as well. So we can see where it goes in the brain. So this is quite an exciting field, and the drugs are still very much advancing through the clinical pathway. And in aging patients, I would say they would also have these benefits for metabolism as well, which is good. So those are just a couple of the enzymes. My own work's been in 5-alpha reductases, but all these other enzymes matter too. And I've just given you a couple of other papers here. Point you to Laura Gathercall and Jeremy Thompson's work looking at 5-beta reductase at the bottom, Ruth Morgan looking at 20-beta reduction. And also, again, Jeremy has also taken a line of work forward similarly to ours to looking at 5-alpha reductases. So I'm just going to tell you a little bit about them. So 5-alpha reductases are enzymes that modify the A ring in the steroid. It takes away the double bond here. And in the case of cortisol, that makes the molecule much less metabolically active. Now, these are the same enzymes that metabolize androgens and a number of other steroids, but they probably are best known in terms of androgens, where they convert testosterone through to dihydrotestosterone, which is the more active androgen, and for example, in the prostate, that happens in male reproductive tissues. So they have again received pharmaceutical interest because of their androgen effects, where blockers of these enzymes are used to attenuate a growth, for example, in benign prostate hyperplasia or prostate cancer. But that led us to hypothesize that, well, if we're using these drugs in people, we're also probably modifying cortisol action by preventing its inactivation, which would predict worse metabolic outcomes. And we studied that first in rodents, looking at knockout mice, trying to see whether or not the animals were more prone to adverse metabolism. And they weren't on a normal diet shown here in blue, but once you put the animals on a high-fat diet, this is the wild types, here's the knockouts, they become more obese, they collect more adipose tissue, and they also accumulate glucocorticoids in the tissues. We were able to give a dose of glucocorticoids and track it and show that it accumulated in the liver and the adipose. So this is sort of what we were simulating in the patients taking the drugs. Their glucose tolerance becomes worse with time. So these are on a normal diet, no change there. But in the red stripes, you can see gradually the glucose tolerance tests getting worse, the fasting insulin going up. They collect fat in their liver. Again, analogous to what Eleanor was talking about. The red dots here are the black globules that populate in the liver. So they actually are developing all the features of the metabolic syndrome, including fibrosis once challenged. We studied this also in humans, where we wanted to test whether the drugs that people use, dutasteride and finasteride, had the similar effect in the human setting. So we did this first in healthy men, where we recruited men in a wide age range, took basal measurements, and then gave them the 2 5-alpha reductase inhibitors that are available on the market. One of them inhibits what's called the type 1 and the type 2, which is we would have expected to have the bigger effect because the type 1 is expressed in the liver, whereas it's metabolic tissues, whereas the type 2 is more expressed in the prostate gland, although it is in the liver as well in humans, and that's inhibited by finasteride. So we tested these 2 drugs, expecting dutasteride to have the greater effect, against tamsulosin as a control, because that was where we're looking at the view of where we're treating benign prostatic hyperplasia, and this is the alpha blocker that's used as an alternative medicine there. We made outcome measures at 3 months, and we had a very nicely balanced group at the outset of the project. They were sort of on the not quite, just a sort of borderline overweight perhaps, but they were certainly not obese. And what we were able to show in the pink here that all the parameters that changed suggested, at least for dutasteride, that people were becoming metabolic disadvantaged. So if the data deflects upwards here, this is worse. So there's a change in body fat, they gained body fat, they increased their fasting insulin, they increased their C-peptide and HOMA-IR. This one at the end, I squeezed on, it's the opposite. This is the rate of disposal of glucose, and it went down with the dutasteride drug. So this did suggest the hypothesis that 5-alpha-reductase could control glucocorticoid levels, and therefore the levels in cells mattered in terms of that intrachronology was true. We've also studied this in population level, looking at type 2 diabetes development in people receiving these drugs in BPH, and you could see about a 30% new increase in the new incidence of type 2 diabetes in both the UK database, CPRD prescribing database, and NHIRD, which is a Taiwanese database, which again, we got the same results. So these data taken together show that these metabolic enzymes in cells really are important in modulating the prevailing level of glucocorticoid available for action. So point number 4, here is a steroid pool, and this is drawn as a blob of adipose. Again, this is what Eleanor was talking about, these atopic blobs of adipose that develop in cells, so naturally in adipose cells, but also in the liver. Steroids are lipophilic, they dissolve in adipose tissue, and this was work of my colleague Mark Nixon, where he gave a tracer in adipose cells in culture, and he was able to show the steroid in red, this was a labeled steroid, pooling in the adipose depots within the cells. And this was done by Raman microscopy. So what we find is that steroids will sit in these pools. It acts as a sort of depot, a sump for the steroid, and it buffers cells so that they're maybe less dynamically changing in relation to the blood levels. But it means that within cells that have got these adipose or ectopic adipose pools, there's definitely an enrichment of glucocorticoids there that can seep out and modify function. So that's an interesting area. So just to finish up now, I think we've finally got to the receptors, and what most people will recognize is that glucocorticoids bind to both the glucocorticoid receptor and the mineralocorticoid receptor. This is well recognized, and it's used as part of the drug design programs. When we want to design a new glucocorticoid, we perhaps don't want it to bind to the mineralocorticoid receptor to avoid hypertension, problems with blood pressure, etc. So that's been known for a number of years. Just move on. And that then feeds into how you design your steroid, because you've got to think about it in 3D, and you can see the steroid here with its rings rotating, but there's one panel where we've got pointy out bits here, this is extrusions, and one panel that's flat, and it's a flat plane that binds to the receptor. So we have to be careful when you're designing the drug how you interfere with its binding site. It's been known for a long time, this is work from Ron de Kloot, that the dynamics of the interactions with these two receptors is different. So there's much more of the mineralocorticoid receptor occupied at low plasma concentrations, where it takes a bit longer for the glucocorticoid receptor to get occupied. And this matters in areas of the brain that aren't protected by 11-beta-HSD2, for example. So the balance of MR and GR occupancy is important. Brain's one particular area where that matters, where glucocorticoids acting on MR are having important functions on feedback mechanisms. So I think it is important to remember that we do need steroids to interact with MR as well. It just depends what the outcome you want from them. It's more complicated though, and somebody whose work I follow is Caroline de Boscher. We want to design glucocorticoids so that we can replace them, but without having all the nasty side effects like the metabolism that can go wrong. And there's a lot more subtleties to the way that the glucocorticoid receptor acts. So this is just this is a simplified diagram from one of her papers showing that the glucocorticoid receptor commonly dimerizes, and in that form it normally drives the metabolic genes, but it can also interact with transcription factors or as a monomer or as many other conformers. And some of these other orientations are more likely to modify inflammation. So there is conceptually, you can see a way to dissect out the roles of the steroids, the different ligands that bind to GR, such that maybe you can design safety and efficacy into new drugs as they come forward. And that certainly there are drugs that are going through trials that are meant to be more selective for the anti-inflammatory work, but none of them, to my knowledge, are in the clinic yet. It's led to a sort of model of thinking about glucocorticoids slightly differently, and that our endogenous glucocorticoids will drive both of these GRs and monomers, but we have now things called semograms and cedigrams, where we've got monomer or dimer driven efficacy. And I think that's something, again, that is very valuable for drug companies to develop. The concept's very good, it's just not quite yet made it to clinic. So again, I suggest this is a group that you would want to follow. Last thing I'm just going to say to finish up is that not all glucocorticoid actions are mediated through the nuclear hormone receptor signaling. We know some of the actions of glucocorticoids are faster, and that's because they can execute non-genomic actions. And that happens maybe at the cell surface. And to date, we don't know the receptors, but for many other steroid classes, these types of receptors have been identified. They're commonly GPCRs. Again, Mike Shipston's written a nice review here. Again, an area to work, because once we can understand those receptors, it gives us more therapeutic targets. So I hope I've given you a view that there's a balance to be struck. There's very many biochemical pathways that are tractable to therapy, and probably new opportunities, some of which we're already pursuing quite vigorously. But it's tricky. There's a lot of different things, and focusing on one aspect of this is probably a little bit too narrow. So with that, I'll finish and just thank you all for your attention.
Thank you very much for the excellent talk. I think we had a great combination of clinical and basic and translational information. So Elena and Ruth are available for a discussion, for answering questions. I think that we already have one, Manuel. I said Demir asks, she says that she finds it quite difficult to understand the CBG kinetics in cortisol binding, as most times we measure total cortisol levels. And is there any kinetic relationship, stable kinetic relationship between CBG and cortisol? She asks various details. She says, for example, we ensure that hydrocortisone is stopped 24 hours prior to a synactin test. Oral contraceptives are discontinued 4 weeks before testing. Other steroids may have varying effects and kinetics. Can you elaborate on thoughts regarding this?
Quite a lot of questions. So
CBG and cortisol,
Yeah, so I think the best person about the kinetics is probably Jeff Hammond. If you want to, a person I would suggest looking at their work. The kinetics are, people describe both the binding constant and the maximum binding constant, and actually there's a series of enzymes that I mentioned, regulation by inflammation. That's because there's an enzyme that actually changes the shape of the CBG and then displaces the cortisol. So there's a few factors in there that you can that modify how much is what proportions free. So you can measure the free proportion, but it's not just a binding constant that is the only factor that you need to think about there. That you're right about the other steroids. I think progesterone certainly it displaces cortisol. So to my knowledge, that has to be quite high levels. So certainly in pregnancy, that can be an issue, but also your CBG levels are very high in pregnancy because they get driven up as well. Oral contraceptives are the other ones that modify the levels of CBG and the binding constant. So there are, yeah, it's complex. That's true. But I think certainly it's more than just binding. It's also these inflammatory signals that are driving the displacement that you've got to look at as well. And I can't say that I know everything about that, but I'd recommend Jeff Hammond as your port of call there, and Mark Nixon in our own lab.
Thank you very much. Elena, would you like to comment anything on this? From a clinical point of view, mostly,
From the clinical point of view, I think that we should, of course, remember the effect on CBG when we measure hormones. Of course, we should suspend oral contraceptive at least 1 month before the measurement. And also we should consider all possible interaction with drugs, for example, the cortisol lowering agents, for example, and also the interference with also the ESE. I'm thinking of metyrapone, for example, and the risk that there is an interference and with a confounding factor due to the increase in 11-desoxycortisol, for example. No? So definitely it's very important to verify the potential effect of the drugs that the patients are taking on the levels, on the hormone levels, of course. But we know very well that it's difficult to interpret the results of UFC. Only one measurement is probably not enough, and probably we never emphasize enough the need for combine different tests and repeat.
Thank you.
Yeah, we have another quick question about if you know that if transdermal estrogen will elevate CBG and cortisol like oral estrogens or not. Do you know about that?
I don't know fully, but I think the actual main transcriptional site of CBG is the liver. So the bigger exposure of the liver to the estrogen will have a bigger effect, I would say, but that I don't know in terms of the clinical application. Maybe Elena knows about that. Yeah.
Yes, so from a clinical point of view, of course, the problem raised from oral contraceptive, transdermal contraceptive are not thought to exert a significant interference effect.
But just to say that most women that take transdermal estrogen most times take progesterone orally, and
Yes.
this may also affect a little bit things. But yes.
It depends, yes.
Okay. So I wanted to ask something because I think from your talk, Ruth, it's quite clear that the metabolism of these hormones is really complicated and it's depending on the tissue and probably is depending on the metabolic status of the patients or in the individuals. You saw that the different levels are different in different tissues or blood or CSF, and I don't know to what extent this is considered or taken into account into the clinics, Elena, because I don't know if all this relationship with the tissue, with the metabolic status, is also considered in the clinics when you are measuring cortisol or any glucocorticoids. I don't know if we already got this consensus between the basic and the clinical management of the glucocorticoids levels.
No, I think we I think we have not reached any consensus on this. You are absolutely right. There are so many influencing factors that I think that it will be really urgent and an unmet need, we could say, try to find a common point between basic scientists and clinical scientists in terms of how to proceed when we have to diagnose Cushing. We know that probably it's the most challenging endocrine situation exactly for this, the intra-individual and inter-individual variability of hormones. And as I said before, and as Ruth magnificently explained, all the possible interference in the entire pathway. So of course, it's also important, I think, to systematically analyze them and have a clear guide on what are the pitfalls of each assays, or at least the most commonly used assays in clinical practice. Have this kind of guide and to something very practical that can be used in the daily clinical life, we could say, in our office, and not only in terms of drugs, but in terms of the technical pitfalls of each assay. So of course, a very direct and confident relationship with the lab is very important. I think it's crucial, probably in endocrinology more than in any other specialization, not to have a direct, a continuous daily contact with the lab biochemistry coordinator, we could say. But I think it's also important to have some basic technical information and basic technical knowledge. And I think that as a kind of self-criticism, no? Sometimes the endocrinologists, we as endocrinologists don't completely have this formation and this kind of knowledge. So probably there is a space that can be filled, and there is space for improvement for us as a clinicians.
I mean, I think the work that I mentioned about the machine learning, that the technology for that's in the lab, and that group are trying to take from what's a very large profile into the most important ones to make it practical for the clinic. And I think that's a really nice bit of work. But other people I'm aware of are also trying to use, metabolomics, which is essentially a research tool, but to try and find a small set of biomarkers that tells you how well your glucocorticoids are getting regulated. And that starts with fishing in a really big pool, but if you can narrow it down to 6 biomarkers that are a kit, then you know that patient's got the right response. That's where we need to meet in the middle, I think, and I think make it practical what we're doing from our end. But yeah, that I think that's on its way. I think there's a lot of people thinking that way, that we see if we can turn these really omics data sets into the small group of things that actually are going to be useful. Mm-hmm.
So we have another question in the chat that it says that if a patient has Cushing syndrome, does he have to apply 6 days rules, or is hypercortisolism sufficient for acute stress?
So the 6 days rules in general are applied to patients with glucocorticoid insufficiency. So when they are on glucocorticoid replacement, and so we instruct them how to change the dose in case of stress. So I guess that the question is related to the fact that patients with hypercortisolism can suffer from acute complications, and actually it has been demonstrated that this patient may have more heart, pulmonary embolism, more acute distress, respiratory distress, so a lot of acute complications. But I think what we have to do in this case is try to reduce cortisol as soon as possible, because definitely the hypercortisolism in Cushing syndrome is already very high. So our challenge is try to reduce it as soon as possible and normalize if possible, in order to also reduce the risk of acute complications. So we should not apply this kind of rules in this phase. And then I don't know if the person who asked this maybe refers to the early post-operative period or something like that. So it's completely different. Of course, we can use different protocols and maintain glucocorticoid replacement or not, and control on a regular basis in order to confirm remission. So this is a different scenario, of course.
Yeah. Okay. So
Any other questions? Any comments? They say if the patient is on a TOMI date, probably this is. So Rana continues the questions and says that if we have a Cushing person who is on therapy, on a TOMI date, do we have to apply 6 days rules? But I think Elena replied already. We try to reduce cortisol and not to.
A TOMI date is given exactly for that, and in a intensive care unit, actually, in a very special and limited cases.
So, Elena, may I ask you something, because you are the clinical person here? When a person takes glucocorticoids exogenously, and especially for rheumatologic reasons and things like that, can you recommend the rule of stopping the glucocorticoids from an endocrine point of view? Just a few points, practical points for the clinicians.
So you mean when the rheumatology are progressively reducing the dose?
Yeah, you know, we have a patient who is on glucocorticoids, and it's now it's time to stop glucocorticoids for the disease. What should we do as endocrinologists? How should we evaluate the patient? How should we stop the glucocorticoids? Because sometimes they ask us, you know? Yeah.
Yes, it's true. So actually, I can say that, for example, in my hospital, so they refer the patient to us, and we, of course, when the patient is at the lowest dose, is about to retire and to suspend glucocorticoids. So we change in general to hydrocortisone, which is more flexible and more physiological, we could say. And so an equivalent doses, of course, and then we control the cortisol reserve, the cortisol production using a basal cortisol, and in case of doubts, we carry out an ACTH test some weeks after, and then we decide to suspend or not according to the response to ACTH test. But I'm sure that you have read a very recent paper by the Newell Price, Dr. Newell Price group, saying that probably is not necessary to shift to hydrocortisone in patients who are taking prednisolone. It has been, they demonstrated that it's feasible to continue with that and safely suspend when the patient is at the lowest dose, of course, doing all the measurement I mentioned, but it's not strictly necessary in most of the patients to shift to hydrocortisone. So it's an interesting aspect, no, from a clinical point of view, because sometimes we ask ourselves if it's really necessary, at least in a subgroup of patients, especially those, depends, of course, on the duration of the prednisolone, of course, the severity of the rheumatologic disease requiring cortisone, of course. So, but these are preliminary data, which, in my opinion, can change the clinical practice and help us to stratify patients according to some potential predictor of immediate or not recovery and need of not hydrocortisone. So the story has not end here, no?
Thank you, thank you. So, Manuel, more questions.
We have a couple more questions. I think one of them is for Ruth. What do you think about FKBP 51 as target in the prevention of treatment of obesity and diabetes?
I have to say, I don't know if I've got an answer for that one. I'm not sure. I know there is a link between that and glucocorticoid signaling, the receptor balance, but yeah, I think I wouldn't be saying anything actually very informed. So I'm sorry, I don't think I can answer you on that one. It's better probably honest about that. So
Okay, we will look for that.
Yeah, sorry.
There is a couple of more clinical questions for Elena. I think in patients with exogenous Cushing syndrome, are the metabolical neurological changes fully reversible after stopping administration? Or are these changes present long term?
Actually, it depends because, as you can imagine, the scenarios are multiples, no? Because, as I said before, depending on many aspects, the dose, the regimens used, but in particular, the underlying disease. Because unfortunately, this disease, rheumatologic disease, for example, are chronic, are long-lasting. They have relapses, frequent relapses. So it's very difficult to say. So there is a confounding influence of underlying disease, which is very strong, and prevent us from being sure that there is a full recovery in these patients. So it has never been described really a full recovery because, as I say, depends on the underlying condition. So if a patient has been treated with high doses of glucocorticoids during very long time, it's quite likely then the recovery is not full, exactly like happens in case of endogenous hypercortisolism. But certainly the model of Cushing is also useful precisely because we can study the effect of glucocorticoids without the confounding effects of the underlying disease, rheumatological or in transplanted patients, for example.
Thank you. And I think, Manuel, we have one last question. Is there any place for prophylactic medications like aspirin in patients with Cushing disease? Because you mentioned that they have atherosclerotic plaques, etc.
So definitely, if a patient has an elevated cardiovascular risk and there is a documented plaque, we actually have to apply the same guidelines as for any other patient with elevated cardiovascular risk and atherosclerosis. So definitely, I support that.
Thank you.
Okay, so I think we are running out of time, right, Lina?
Yeah, it was very interesting and many questions and much discussion. Thank you so much. So, Manuel.
And I have to say that we had a lot of participants in this session, so I think it's a topic that is really interesting for the endocrinologists around Europe. So thank you so much for sharing your expertise in this field with us. I think it was a really insightful and really interesting session, both from a clinical and basic translational point of view. So thank you so much, Elena and Ruth, for being here with us. It was a pleasure for us. So if you want to close the session, Lina.
Yeah, sure. I would like also to thank Ruth and Elena. I think that we had a great combination of science and clinical information. I would like to thank also all the participants. Great success. And also to remind you that we have future sessions. The next one will be on April 25th and the next one on June. So keep informed, stay tuned, and more Spotlight on Science is coming soon. Manuel, thank you for co-chairing. Thank you again.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye. Thank
Bye-bye.
you.
Bye.